Good morning. I'm Alan Weil, Editor-in-Chief of Health Affairs. We're so happy to have you with us today for a briefing in conjunction with the release of the 2019 Commonwealth Fund International Health Policy Survey. Hot off the press, we have a printout here, and it will appear in the next issue of the journal. This is a great time for us to be able to release this information. We have a long-standing partnership with the Commonwealth Fund in releasing the survey, and it's a great privilege to be able to hold up our end of that partnership. In our field of research, we often ask about the impact of the work, and I think this publication and its long series of which it's a part are very strong evidence of impact. In the first place, having comparative data across countries gives everyone information that they wouldn't otherwise have. It gives them benchmarks to work against. It gives a check-in of where your own country is, where your own country's performance stands, and it creates an opportunity for conversation and learning. If you see better performance in another location, it's an opportunity to pick up the phone or hop on a plane or take a boat, or whatever your preference is, to another location to find out what they are doing. In and of itself, the comparison is not proof of the effects of policy, but it's certainly indicative of an opportunity for learning and an opportunity for improvement. And I will just say here in the United States, the Commonwealth Fund has really changed the conversation over a period of decades. This is not something you do in a year, about the performance of the American healthcare system. Earlier in my career, it was commonplace for people to always talk about how we have the best healthcare system in the world. And there are certainly tremendous strengths in the American healthcare system. But year after year of evidence, much of it released by the Commonwealth Fund, has made it clear that there are major shortcomings in the American healthcare system, and that it is not helpful to use a shorthand like the best healthcare system in the world. It's a cause for complacency that we can't afford. And so if we're looking for the impact of research, I believe that this series demonstrates how valuable it can be to make an investment, to sustain that investment in comparative work. And we've seen the effects here in the United States, and I hear stories around the world of those effects as well. And finally, I just want to acknowledge that we've had many year partnership with Robin Osborne, who I got to say good morning to, who's moved into a new role. I came into the office yesterday to find out that Reginald Williams has been selected to take over the international portfolio, just in time to be here for the release. We're happy you're here. But I also know that in the interim, Melinda Abrams stepped in and did a lot of what it took to pull today's event together. And although I can't see her at the moment, there she is. I do want to acknowledge how much went into making today possible. So without further ado, it's my pleasure to introduce to you David Blumenthal, President of the Commonwealth Fund, former Samuel Thier Professor of Medicine at Harvard Medical School, Chief Health Information and Innovation Officer at Partners, Director of the Office of National Coordinator for Health Information Technology, and more, and a longtime colleague. David, I'll turn it over to you.
Well, thank you so much, Alan, and thanks to Health Affairs for this long-term and mutually beneficial partnership, and for the kind words you had to say about the impact of our joint work in this area. I think it's true. I hope it's true. I know we're going to endeavor to make it more true in the future. I'm delighted to be here to be present for the release of this new study and these new data. This is our 21st International Health Policy Survey. That's a long tradition and a long time to be doing the same thing. Of course, it's not the same thing. We rotate the focus of the survey every 3 years. But the longevity of the work speaks to our 101-year history at the Commonwealth Fund and to our enduring interest and commitment throughout that time in international learning and in international improvement and constructive dialogue across international boundaries. There are a number of concrete examples of how that has benefited our system. One of them being the hospice model, which the Commonwealth Fund gratefully imported from our colleagues across the pond in the UK some 20 or 30, well, probably 30 or 40 years ago. We funded the first demonstration of hospice, having learned about it in the United Kingdom. We could not do this work alone. We don't do it alone. And our partners around the world are absolutely essential to this work, including the survey work we're releasing today, but also to many other aspects of the Commonwealth's international and cross-national studies. The 2019 survey includes 16 funding partners. Robin's ability to juggle all these was kind of magical, so that's something that she has given us the legacy of during her tenure. 9 different countries, and in addition to financial support, our partners continuously provide incredibly important guidance on questionnaire development, language, and interpretation of the results of the survey, and on how to move forward from the surveys to policy. It's really our honor to be able to work with these partners from around the world, and we are deeply appreciative that so many of them made the effort to come from across the Atlantic and across the Pacific to join us here today. This year's survey focuses on primary care physicians and the challenges they face. I'm a primary care physician. I spent 35 years seeing patients as a primary care physician, so I am far from unbiased as to the importance of this work. But our work across the world demonstrates again and again that primary care is the glue that creates effective healthcare systems. Primary care in many forms, but primary care in its essence plays that role. And that gives me a special interest in today's results and how they will be interpreted by our guests on our panels. Before we dive into the program, I want to take a moment to thank everyone who made this work possible. In addition to our survey partners, we have government representatives and experts here from, as I mentioned, from far and wide. I also want to acknowledge our Harkness Fellows, past and present. At virtually every gathering we have of an international nature, we find our Harkness Fellows present, often in roles well past their fellowship. But we have some on our panel today and some in the audience, and we're always delighted to see them and work with them. Again, our thanks to Alan and the team at Health Affairs. This partnership is a terrific one for us. We work hard to make sure that our work meets Health Affairs' high standards, and they make us meet those standards. So it's a mutually beneficial relationship. And the authors from my colleagues at the fund who have put this work together, created the surveys, directed the surveys, and then wrote the work that will appear in Health Affairs. I mentioned Robin. Robin has put an indelible imprint and created a lasting legacy for our international program. It would not be what it is today without Robin, and she will be greatly missed. Fortunately, she's staying with us in a part-time capacity for a period of time, as yet to be determined. It's been 22 years with Robin at the helm of our international program, and that is a very long time for which we are very grateful to her. But we're also delighted to be able to report that Reggie Williams is taking her place. Reggie is terrifically well suited to provide the leadership for the program as we move into the 2020s, and we are very confident that we will be as committed and as deeply involved and as creative in our international work going forward as we have been in the past under Reggie's leadership. So thank you all again for joining us. I look forward to the morning's work and presentations, and thanks again to Alan and to everyone.
Thank you, David. The order of the day is fairly straightforward. Michelle Doty from the fund will present the findings, and then we'll have two panels. The first is a higher level reaction, country level reaction to the findings. We'll take a break, and then the second will be a more focused session looking at the role of primary care in integrating health and social care. And we'll have a nice closing by Noam Levey, who will make sense of all of this, if it isn't already made already. So let's go ahead and get to the heart of the matter, which is the findings from the survey. Michelle Doty is the Vice President of Survey Research and Evaluation at the Commonwealth Fund, and I invite you up to present the findings. Thank you.
Good morning and good afternoon for some of us who are joining us on the web. I'm delighted to be here with you this morning to discuss the findings from the 2019 Commonwealth Fund International Health Policy Survey published yesterday in Health Affairs. Before we begin, I would like to acknowledge my co-authors Rosa Tikkanen, Arnav Shah, and Eric Schneider, as well as the survey firm SSRS, who oversees and executes this survey. We are also grateful to our survey partners. As David said, this is a year-long effort, and we would not be able to conduct this survey or do this important benchmarking work without you. So thank you. We really value your partnership and your continued support. First, a little context for why we have focused this research on care coordination in primary care. Primary care is the backbone of any high-performing healthcare system. A strong primary care system can help prevent illness, manage patients' care across multiple providers, and reduce healthcare costs. Essential to such a system is effective communication and coordination. Poor coordination leads to fragmentations, inefficiencies, and a higher cost of care. Primary care physicians sit at the center of patients' healthcare experiences, often aware of their patients' medical needs and social needs. Primary care physicians often must communicate and exchange information with specialists, hospitals, other providers, social service providers, and of course, the patients themselves. Getting care coordination right is a challenge. With cross-national studies such as this one, countries can gauge where health systems are falling behind, where they are keeping pace, and possible paths to improvement. Let's turn to the findings. The survey interviewed over 13,000 primary care physicians across 11 countries. In each country, nationally representative samples of primary care physicians were drawn at random. The time in the field ranged from 7 to 19 weeks, and response rates varied from 15 to 49%. More details about the data and methods are also included in the Health Affairs article. The survey found that the U.S. was an outlier in lacking extended access to primary care, such as home visits and after-hours care. Practices in the U.S. and Canada are much less likely than those in other countries to provide after-hours arrangements so that patients can be seen when the practice is closed without having to go to the ED. In contrast, the vast majority of physicians in Germany, New Zealand, Norway, and the Netherlands provide aftercare arrangements. When we look at indicators of coordination with clinicians across settings, we see that primary care physicians' the ability to communicate and share information with other providers varies across countries. This slide is about communication with specialists. Most physicians usually send information to specialists, the chart on your left. But as you can see, physicians in all countries were more likely to report information, being able to send information to specialists rather than receive it from them. When it comes to communicating with after-hours care, emergency departments, and hospitals, a few countries, United Kingdom, the Netherlands, Norway, and New Zealand stand out. Large majorities of physicians in the UK, New Zealand, and Netherlands are usually notified when their patients are seen by after-hours care. This compares to a little over a third or fewer primary care physicians in the US, Germany, Canada, and far fewer in Sweden and France. This pattern is similar when we look at the extent to which physicians receive notifications from emergency departments and hospitals. About half of physicians in Canada and the US said that they are usually notified when their patient has been seen in an emergency department, compared to 2/3 or more physicians in the UK, Netherlands, and New Zealand. Rates of notification are even lower in Sweden and France. Communication between home-based care providers is less than optimal across countries. You can see that no country stands out. There's a lot of room to improve communication between home care providers and primary care. When we asked about sharing patient information with other providers, most physicians in Sweden, New Zealand, the Netherlands, and Norway reported being able to exchange patient information, such as clinical summaries and lab tests, with physicians outside their practice. About half of physicians in the US, Australia, Switzerland reported this functionality, and even fewer in Germany and Canada. When we looked at indicators related to facilitating communication with patients, we found that for the most part, physicians offer their patients the option to communicate with them via email or a secure website. For example, 3/4 of US physicians reported they offered patients the option to communicate with them about a medical question or a concern. Far fewer physicians in Canada, Australia, and France offer this option. Large majorities of US physicians join their counterparts in the Netherlands, New Zealand in providing patient portals or web access that makes it easier for patients to request refills online. This functionality is practically ubiquitous in primary care practice in Norway, the UK, and Sweden. Physicians in Canada, France, Germany, and Switzerland were less likely than others to report offering these options. On a brighter note for the US physicians were among the most frequent to offer web access or patient portals so that patients can access their health data and view patient summaries or their lab results. These patient-facing electronic services reflect the priority placed by the US federal government on giving patients access to the healthcare data and could play an important role in helping patients coordinate their own care in the future. At the current time, primary care physicians across countries report major challenges in coordinating patients' care with social services and other community providers. For example, about a third or more of physicians in the US, Germany, Canada, UK, Australia, and France told us that lacking referral systems is a major challenge. Other challenges include inadequate staffing to make referrals and a lack of responsiveness from social service agencies about what services patients received or needed. Routine coordination with social service agencies to meet health-related social needs of patients is a work in progress in most countries, except in Germany and the UK, where large majorities of physicians indicate that they or someone else in their practice frequently coordinates care with social services or other community providers. If primary care physicians are asked to take on more responsibility for coordinating patients' care with social services, policymakers will need to take into account the challenges, the lack of referral systems, inadequate staffing that physicians are already facing. The survey highlights areas of coordination that are robust in some countries, but they also point to challenges in achieving more coordinated care. From the U.S. perspective, this study shows that U.S. primary care physicians fall short in providing extended access to patients. They fall short in provider-to-provider communications and in exchanging patient information electronically across settings. But they are also among the most frequent to report offering patient portals web access to facilitate communications and access to their own health information. As other countries, they face challenges in coordinating patients' care with social services. To help primary care physicians better coordinate their patients' diverse needs, some strategies rise to the top for consideration. First, for the U.S., the findings call for a stronger commitment by government and other payers to primary care. Primary care practices in the U.S. are challenged by a health system that lacks universal coverage, imposes high out-of-pocket spending, which makes it difficult to make primary care accessible. National policies for primary care that we see in all other countries surveyed, such as guaranteed access and mandatory after-hours arrangements, could go a long way in the United States. Across countries, remove regulatory, technical, and economic barriers to sharing patient information with providers across settings. National policies can help advance the adoption of health information technologies in clinical settings to facilitate two-way communications with providers, as was seen with the HITECH Act in the United States. In Norway, uses a national health network that provides efficient and secure electronic exchange of information between all relevant health and social service providers. Consider digital technology to streamline and automate documenting patients' social needs and providing referrals for needed services. It is possible to develop and implement automated screening and referral processes with existing electronic medical record systems. Practices can also consider electronic community directories of community-based organizations. Make it easier for social services and care organizations to work together with primary care. Consider alternative models of care, such as co-location. Develop payment systems that cover the cost of providing social services that are essential to the medical care. A good example is medically prescribing food for diabetics, which have been proven to be effective in reducing costs of care. The United States lags most of the world in the priority it assigns to primary care, but it does have strengths to build on. Benchmarking U.S. healthcare performance against other high-income countries is one way to point to a higher performing primary care. I look forward to hearing from our panelists who will help us make sense of this data and will also give us an opportunity to delve further into how to improve the coordination of patients' medical and health-related social needs. Thank you.
So I'm going to suggest that if there are questions associated with the survey, because we're going to get into a broader country-by-country policy discussion momentarily. But if there are questions about the data, the findings, Michelle would be exactly the right person to answer those. So if we have those sorts of questions, we can take them now so that we're all working from the same base of information. And let's get a microphone to you so that, and yes.
Tim McManus with the National Business Group on Health. Does your survey include questions around emerging services that have come up, like second opinion services, virtual telemedicine, and things like that?
We included some questions about video monitoring, and but we did not include questions about telehealth. Yeah.
Other questions of this nature? Yes, again, if you can wait for the microphone.
I think at least, the reporting on burnout of physicians in the U.S. is quite pervasive. Did you ask anything about burnout in other countries? Because in some stuff I've read on the UK, there's a lot of pressure on the primary care providers. I'm just curious.
We did ask questions about that, and we did not include it in the survey, but it's forthcoming, so stay tuned.
Okay, I want to keep these narrow to the survey content, and we've got 3 more questions here.
Julie Shills with Mathematica. I'm curious if you standardized the definition of social services, because I anticipate that perhaps among countries there's a slightly different definition of that.
That is a great question. I believe the panelists will also be delving into this area very significantly in the latter panel, but we did provide some definitions when we asked about screening for social services, which prompts people to think about these services. And the question regarding how often, frequently providers coordinate with social service providers is left broad. Yeah.
Right up here.
Bob Griss with the Institute of Social Medicine and Community Health. My question is how this survey compares with other international surveys, like, for example, the OECD data. Is there a section of your report that looks at the differences between findings and methodology?
The article does not cover that, but as part of the methodology group that creates this questionnaire, we do work in tandem with our partners at OECD. OECD does include a lot of our indicators in their reporting, so there is collaboration on that front.
One last question here.
I'm Dr. Caroline Poplin. I'm a primary care physician. Did the survey look at reimbursement for primary care providers and other kinds of specialists or providers?
No, we did not ask about that.
You should have.
Can you join our development methodology group to develop questionnaires for the next time? Fantastic.
Great. Well, this is a great introduction with the data. Thank you, Michelle.
Thank you.
So I'll ask our first panelist to come join us. We'll get the name tags up here so folks know where to sit. As noted, our first conversation is going to be a somewhat higher level country by country reaction to the findings, whatever it prompts. We're fairly broad in our interest in how people respond to the findings in the survey. You'll be hearing from Charles Keckler, Associate Deputy Secretary in the U.S. Department of Health and Human Services, Presidential Scholar at the Schar School of Policy and Government at George Mason University, former Deputy Assistant Secretary for Policy at HHS under President George Bush. Juliet Rumball-Smith, a public health physician and epidemiologist who recently joined New Zealand's Ministry of Health as Clinical Chief Advisor. Ian Dodge is the National Director of Strategy at NHS England, formerly Director of the NHS Group and Head of Policy Profession for the Department of Health. He's also an adjunct professor at Imperial College London. Jane Philpott, medical doctor and associate professor in the University of Toronto's Faculty of Medicine, former member of Parliament in Canada, serving a number of cabinet positions between 2015 and 2019, including Minister of Health. And Catherine Grenier, Director of Quality Improvement and Safety of Care at the French National Authority for Health. So we have 5 countries represented here. And we've asked each of our speakers to take not more than 5 minutes to give some higher level reactions, and then we'll open it up for a conversation. So Charles, I'll turn first to you.
Is this working? Thank you very much, Alan. And my apologies, I'm going to have to leave around 10. To get back to it, I really appreciate the focus of this year's survey on care coordination. That is an area which the department, and in particular the Office of the Deputy Secretary, is working on specifically. Care coordination is it's valuable in and of itself, but we consider it contributory to moving to a value-based system. And some of the things that we're working on actually were referenced there in the presentation indirectly, in that there are a number of regulatory barriers to successful care coordination that we see with regard to the Stark Law and anti-kickback statutes that can be corrected. And in this, I would also add, of course, our forthcoming interoperability rules, which also we expect to help address some of these issues. So, care coordination has, a role in improving clinical outcomes, but also a role in reducing cost. And if you add both of those together, you come up with value-based. So I think that this is an interesting survey. The next step sort of piece for me as a reaction is to think about it in relation to what I always think about when I see these things, which is clinical outcomes. And to see, we have, evidence and strong hypotheses around care coordination, and it's great that it sort of breaks it down into the specific elements of what care coordination means, but then tying those at that granular level to how clinical outcomes in the system can improve is something that, of course, would be particularly useful from a policy perspective, and it would also help informally in this issue of weighting, right? We see, a whole series of survey results. I think there's 26 of them in the chart pack, and understanding which ones are the most impactful and which ones also potentially can substitute for one another. So, for instance, some of the issues with regard to after-hours access could also partially be addressed by the ability for technology to get in there and have some telehealth or for the patients. So those are my immediate reactions. I'm certainly interested where we do well and where we need to improve, and the particular issue of the very first indicator there, which really has to do with house calls, I think is an interesting one. And I'm sort of curious. I mean, it certainly must have a specific cause of why house calls have, and part of it probably does have to do with reimbursement, which was had the question earlier. There's from a policy perspective, something like that, you want to dig in and disaggregate it, in particular by thinking about Medicare patients where there's a reimbursement policy, and then the rest of the population with the other payers, and think about that. So if it's Medicare, that's sort of one set of solutions, and there have been some pilots, as some of you probably know, with regard to independence at home and in thinking about changing the reimbursement structure for house call. And there is some positive evidence as well that can save money. But then there's the issue that maybe you can also do some of those things through technology. And then outside of the context of Medicare, that's a sort of another sort of interesting issue about incentives and doctors that I think needs to be kind of disaggregated and explored. So those are my immediate reactions. Thank you for the survey. This is a helpful benchmark. We ourselves are pursuing some additional benchmarks beyond the OECD and are always, find this valuable in evidence. I bring greetings from the Deputy Secretary, in fact, who's meeting with his international colleagues directly on the other side of the world in Oman at the World Health Organization. Thank you.
Just because we're going to lose you at questions and we have an international audience, I wonder if you could take a moment to expand on the stark anti-kickback, very U.S. policy kinds of things, and just go a bit deeper in what the problem is and how you view the solutions.
So the stark and anti-kickback laws are, very well-intentioned laws that were designed to prevent essentially self-dealing. So physicians making recommendations and suggesting you go where they might have this sort of financial interest. So they say, oh, go see this specialist, but it turns that there's sort of a kickback or some kind of same kind of practice, for example. And so those, what those have done over time is we found those have limited the sort of the business flexibility and the ability, especially as we move beyond this sort of single physician or small physician practice in terms of how care is provided, that these have caused a number of problems. And so we are really looking at what we call a regulatory sprint to coordinated care to really reform these laws to allow business models that are that enable physicians to provide coordinated care and coordinate with one another, because essentially it's a way to limit coordination in certain ways. And as part of that, we're also looking at the HIPAA laws as well that limit data sharing, as well as the laws specific to substance abuse providers, 42 CFR Part 2, which limit the coordination between specialty substance use providers and primary care physicians. So there's a number of these laws, all of which had good intentions, but which we're looking to improve specifically in the context of allowing better business models for coordinated care and sharing of information for that purpose.
Thank you. Thank you for the clarification. Juliet.
Is this on? I just want to say that it's just such a delight to be here, and I'm always so humbled to be in back with the Commonwealth Fund family. I'm a 2016-17 Harkness Fellow, so I'm just so privileged to be here. Thank you for asking me. So I'd like to provide some context first about the New Zealand health system, and I'll speak slowly in case my accent is difficult to understand, unless you're a Flight of the Conchords fan. So, one at the back. So in New Zealand, secondary, tertiary and emergency care is government funded and is free for patients at point of care. And oddly, primary care is not. So it's essentially a subsidised fee-for-service system with co-payments required for all patients aged 14 years and over. Although the co-payments reduce for those who are most socioeconomically disadvantaged. So I had three main takeaways from the survey, and I'm so grateful for the survey because it gives us information about the New Zealand primary care providers that we would never have otherwise. So with respect to care coordination, my three main takeaways were as follows, is that firstly, it does really demonstrate the evolution of clinical digitisation in the New Zealand health sector, in that primary care were early adopters and were international exemplars in this area around a decade ago, and they are 100% digital. So all information that flows out of primary care is digital and efficient and clear. However, information from other sectors is less in that way. So that's due to two reasons, in that secondary and tertiary care, the hospitals are lagging in this respect in digital technology adoption, but also the way our sector is operationally structured in terms of referrals must come from primary care. The gatekeeper role is strong. So secondly, I thought it really demonstrated our structural and process settings of healthcare delivery. So we have contractual requirements that primary care doctors must provide after-hours care. And we also have a reimbursement system where there is clawback if your patient goes and sees another doctor or sees an after-hour care So there's a financial disincentive for this. I noticed the poor care coordination when you cross into the social sector, and this really reflects the siloed nature of social sector services and health services. And there's been two major movements to combat that siloed nature. So the first is direct commissioning of social services by health. So health services now are in the business of housing, and they're in the business of other social determinants. And the other is co-location of other professions in primary care. But there is still no financial incentive for primary care physicians to refer to those providers. So they're co-located, there's better relationships, but it's still fairly siloed. Finally, I thought that the survey did, we look pretty good, but I thought it still showed that we are relatively medically provider-centric, and that patient experience is not a market driver. All patients in New Zealand must sign on with a primary health organisation, and you go to your local general practitioner, and there might be some shopping around, but prices are fairly stable. And so the use of technology such as patient portals and e-prescriptions is not strong, and that's because they're still working out the reimbursement models not only for the infrastructure but also for those services. So I don't think there's much incentive for the doctors themselves to be offering these streamlined services and improving access in that way. I think we need to watch that space carefully, because there's the potential for unintended consequences there. And I'm particularly thinking about increasing the non-clinical time doctors are required to put in. I'm hearing a lot about that from the sector at the moment. But particularly I'm thinking about high needs patients and patients in lower socioeconomic groups who might be driven to access care more in those non-face-to-face ways, and I'm worried about the impact of quality of care that they receive and potentially on their outcomes. So I'm watching that. Thank you.
Excellent. Thank you so much. Ian.
Thank you, and thank you very much for inviting me here. Great to see the survey results. The one that probably most leapt off the page for me, picking up on your comment, Juliet, around the evolution of digital, was slide 18 in the pack around video consultations. Clearly that's only one channel, and we're very interested in web-based, and actually nearly 150 years after its invention, actually using the telephone better rather than just physical face-to-face, something we've belatedly got round to. And Sweden, and the fact that they're a third of patients frequently having video consultations. I think that's really worthy of further investigation, certainly on our part. Overall, it struck me that pretty much all countries have got a long way to go on this, which is one of the reasons why it's so interesting. You've been highlighting a critical challenge. And as we think about this in a UK context, the first point I'd make is around how we manage within an existing capacity. And that capacity is constrained. We've had relatively constrained financial funding for the health service in the UK in the last 9 years. And we have very significant perceived workload issues and workforce issues around numbers of GPs in particular. A lot of issues as well around premises. So our biggest issue at the moment is basically capacity. And it's hard to disentangle the questions of what are the policy effects versus the underlying funding and infrastructure and workforce issues. Within that fixed quantum, there's always a debate about how we get the best blend between the stuff that citizens tend to care about most and the stuff that the health service tends to care about most. And if you look in the UK, probably the biggest single source of complaints about the NHS at the moment is actually declining patient satisfaction with access to general practice. So behind your high-level metrics around extended access is the question of, well, just how easy is it to get to see a primary care professional, either for urgent access or indeed routine access. And in our system, that's really critical because we have a ratio of 19-1 of primary medical appointments versus emergency department appointments, 310 million a year versus 16.5 million a year. And that utilization ratio is really critical for the sustainability of the NHS overall. And so how we blend the urgent care access versus the anticipatory integrated care is a key and important conundrum. There's a lot of really interesting things we're doing in England at the moment on primary care. It's a really exciting time to be working in the health service, a lot of which I think will make a big impact here. So we've got a big program of investment. We're trying to expand the number of GPs, but we've also been driving really hard on using other professionals within primary medical services, pharmacists. At the moment, we've got something like 30 to 40,000 non-GP professionals who are active. We're planning to expand that by another 20,000, by over 50% in the next 4 years, and we've got dedicated funding to do that. Pharmacists. So moving from dispensing towards consultation, social prescribing, which you mentioned in the article, community paramedics, physician associates, and physiotherapists. I mean, there's a real mixture of additional roles coming in. We're getting primary care to work at scale, and we've structured all the financial incentives to support primary care networks. So we've got roughly 7,000 independent GP practices. They've now formed into 1,259 networks, typically 30 to 50,000, and we're structuring a lot of the discretionary funding around those networks. We're trying to drive the personalisation agenda. So one of the best ways we think to coordinate care is to give power to patients through things like personal health budgets so they can decide themselves how they do the coordination. It's a theme we haven't explored a lot in this paper, as well as personalised care and support planning. And then finally, on this practical question of the integration with other community-based services, we're looking to develop service specifications for how all of the primary care networks will need to work with their community providers. We're developing interlocking specifications, for example, about how they support care homes, including by proactively doing weekly care home rounds, doing structured medication reviews, stopping falls, stopping polypharmacy, avoidable ambulance conveyances, and we've had great proof of this from our initial pilots. So there's a lot of work we're doing which we think will make a difference in this space. Thank you.
Great, thank you. Jane.
Well, thank you very much, and good morning, everyone. I want to congratulate and thank Health Affairs and the Commonwealth Fund for hosting this very valuable event, and congratulations to all, including Michelle, for her leadership on the survey. I'm delighted, personally, as a primary care physician, to see the focus on primary care. I think the U.S. occasionally bashes themselves a little bit on their lack of focus on primary care, but I think the entire world will forever be dedicated to the work of the late Barbara Starfield and her team for documenting better than anyone ever has before that until the countries of the world have strong systems of primary care, we will not be able to get great health outcomes at an affordable cost in a way that is both equitable and accessible. And so we continue to strive together to be able to do that, and I'm delighted to see that that's the focus of this study. One of the great things about an international survey like this is it gives you an opportunity to self-reflect and to self-criticize, and I'm immediately always drawn to the places where Canada ranks most poorly because that's what drives us to get better. And so I wanted to focus my comments on the areas where I think Canada had rather unflattering results, and that's in the area of electronic communication. And you may have noticed one slide in which we were worst of all, and that was in the ability for patients to be able to communicate by email with their primary care provider or through a secure website, where we were last of all at 9% or 22%, and Sweden had 91%. But in that whole series of electronic communications, Canada did poorly in terms of being able to book appointments online, in terms of requesting referrals online, and this really important piece around exchanging clinical summaries as well as exchanging medication lists, which to me is an incredible key to quality care, that all providers in the circle of care need to be looking at the very same medication list. Canada should be able to do better. One of the things that we're noted for, of course, is being the second largest country in the world with 10 million square kilometers of space. So there's a real driver for us to be able to figure out how we can communicate electronically. We can't all get to see each other face to face. We have an obligation to deal with that. One of my roles currently is that I'm special advisor to a group of 49 First Nations, Indigenous communities, 32 of which are only accessible by air. And our country spends currently about $500 million a year on medical transport for First Nations. So as I was saying to Onil Bhattacharyya last night, if we could just take 10% of that money and invest it in how we're going to actually be able to deliver virtual care, it would both provide better care and save us a lot of money. And of course, there's a growing recognition of the environmental cost of medical travel as well. Canadians, as those in your countries, are routinely shopping, banking, studying online. Healthcare seems to be the last frontier, and I believe that Canada has an obligation to try to lead the world in remote care delivery because of our geographic makeup. And it's a time when communication technology is literally at our fingertips every single day, but these tools are not embedded into the routine practices of our healthcare delivery. And I personally am concerned about the fact that for-profit delivery of care virtually is moving well beyond our public systems of care, for which we are proud in Canada, but we need to make sure that as remote care delivery becomes common, that it's also high quality care. The study does a good job at looking at what the barriers are, and it notes a number of them, including, of course, the technical barriers. I think the technical barriers are frankly the least of our problems, and it does note some of the other areas, including, of course, regulatory barriers, the building of trust around communication electronically, and financial barriers. Again, with financial barriers, though, we've invested an extraordinary amount of money. I have colleagues here from Canada Health Infoway. Canada's invested almost $2.5 billion in Canada Health Infoway. What we've failed to do in Canada is attach strings to it that I think other countries have perhaps done better at, in terms of making sure that integration of that virtual care is mandated and the funds don't flow unless it is well integrated. A couple of things that I think weren't mentioned in the study that we could point to is, of course, the privacy concerns that others have mentioned. Trying to get the balance between making sure that there's lots of competition in the market, but not so much competition that integration becomes too challenging. And of course, the final thing I'll say is provider buy-in, and particularly physician buy-in, in a day where we know the benefits of access to electronic communication, but we need to provide support for transition and, of course, the incentives that others have referred to. And I look forward to our further conversation. Thank you very much. Chimagwech.
Thank you. Catherine.
Yes. Thank you for this invitation to speak by Health Affairs and the Commonwealth. The participation to this international study is really important for France, and I'm sorry for my English, which is not very good, and I will try to do my best, but I hope you will be empathic. This study highlights some challenge for France. I will try to give you an overview on how the National Health Plan will consider these challenges. This new plan has been launched in 2018 by President Macron and his ministry, Agnès Buzyn, who you know and who was my last president. And I will try to put to speak about 4 challenges. The first one is to remove social and economic barriers. In France, a significant number of individuals are still going untreated for socio-economic reasons. Specific measures should make it possible to reduce this inequality and respond to the need of individuals, particularly the most vulnerable. Also, France is renowned for its high level of investment in healthcare provision. We need to improve access to health insurance. This is at least partly due to complex nature of procedure and arrangements. At the present time, the payable part, that is to say the proportion of health care costs for which individuals are really liable, amounts to 8%, and for certain type of healthcare it is much higher, for example dental care or medical optical equipments. The current policy focuses on this point and has implemented rules to permit free of charge access to this type of equipments. The second challenge is to improve access of health, meeting territorial needs. The pressure on access to healthcare are likely to increase due to decrease of the number of GP in France and to certain territories' lack of appeal. The study of the Commonwealth showed that 95% of primary care physicians make home visits in France, and it is a good result in comparison with other countries, but the survey also confirms that we have a problem with after-hours access of care. This issue has been identified, and ambulatory care professionals are called on to develop new organization named Local Health Professionals Community. In this new contract with the French National Health Insurance, they have to make arrangements for a better response to the needs of population, particularly to avoid the emergency department overuse. The National Health Insurance has given the objective of 2,000 communities on the national scale. Several other actions have been developed to promote collective organization in ambulatory care, and GP may be helped by medical assistance for activities which can be delegated. We also work on delegation framework to focus medical practitioners on specifically medical activities. To meet territorial needs, the use of digital technology such as telemedicine, has been also promoted, and the national policy is supporting local initiatives which are tailored to the specific local needs and resources. The third challenge is the transformation of territorial care provision, and first structuring primary health care to ensure quality and continuity of the individual pathways. The last one is to ensure quality and safety and appropriateness of care. The continuity of care is crucial for that. Sectors providing medical and social services need to better complement each other with a specific focus on transition between ambulatory care providers and institutions. The study shows that the continuity of care is relatively satisfying for GP when it involved a professional-to-professional communication, with not so bad results on sharing patient clinical summaries, test results, etc. probably because of habits and historical individual networks. But the studies also show that the results are pretty poor when it involved institutional relationship, with a notification reported by 24% of them when patients have been seen in an emergency department, and even 14% for information received within 48 hours after hospital discharge. I think this problem is linked by the lack of digital communication and structured digital communication. So that's the 4 challenges I think are the most important in France. Thank you.
Thank you. Okay. This was a great set of perspectives, and what I want to try to do is pull a few themes out that some of you spoke about and others did not, and just try to get a little bit of a tour across the different countries. One theme that I heard is the use of embedding resources within a clinical practice relative to having those resources based in a community that a practice can draw upon. This applies to all of the domains, whether it's after-hour coverage, whether it's electronic communications, whether it's linkages with social care providers. There's a tension between how much you want to have cited within the individual practice and how much of an infrastructure those clinicians can draw upon. I wonder if just we could go a little deeper on that continuum, and you could talk a little bit about where you see your country and whether you see pressure or interest in moving one direction or another on that continuum. Juliet, do you want to start?
Sure. Thank you. Thank you. So that's a really interesting point, and I think one of the first things to clarify in our minds is the difference between a workforce. So, for example, a social worker may work in the community, or they might work in social services, or they might work in a clinical practice. So they have a skill set, but they might also have an organisational requirements or mission of what they're doing, and they may not mix. So with respect to having them in the community, so New Zealand's always had that, and now we are trying to make bridges between having these professions located in a practice, but also moving more towards the UK model that you described, Ian, where we might have a network that might share access to a profession or a set of services, and those are located in the community. My take on this is that they are still less popular than being co-located, and that even if they don't talk to each other, they don't share the same medical records, the preference is for them to be in the clinic. And there's a couple of reasons for that. Firstly, there's a sense of kind of ownership and relationships. But secondly, we're moving more towards what we would call a soft handover, a warm handover. So it's designed so that patients don't have to wait and don't have to come back and have difficulty accessing the service, and the transport barriers and the childcare barriers and all of that sort of thing. So what we're trying to do is provide access to these other services immediately. So a patient might come into a primary care practice and they might identify, for example, mental health needs or social needs, and the idea is that the general practitioner or the practice nurse will be able to immediately take them down the hall and have a warm handover with that service. And the research has shown that by doing that, you get better engagement, you get fewer number of visits required. So it's moved from 6 down to only 2 or 3. And a greater, more immediate impact on patient outcomes. And so the area that we are focusing on in New Zealand at the moment for this is mental health, and there's been a huge initiative that is underway around this. And it's fascinating because what we've seen is whole new workforces developed with the community health workers, health improvement practitioners, coaches, behavioural coaches that are all being located within clinics and have this warm handover structure. Hopefully that's answered a little.
That's really interesting, very interesting, yes. Ian, do you want?
So we're making a big bet on at one end of the continuum, which is that we're fattening up core general practice rather than just relying on wraparound services and staff provided by others. But it's a both and. So we still have a structure of our 7,000 separate practices. They have, in essence, contracts for life. So it's up to them if they want to merge unless there's particular performance issues. But we've structured the money and investment. So crudely speaking, pay and basic infrastructure costs we're keeping pretty flat in real terms, and we're putting all the discretionary money into networks, which they have voluntarily formed. So we're actually putting £1.8 billion into networks by 2023-24. And most of that is going into staff, because as independent contractors, we don't want it to go into basically excess profits. In 1966, following a crisis in general practice in England, there was a reimbursement mechanism for nurses because nurses weren't typically employed by GP practices. That rapidly led to nurse practitioners in general practice. And we're doing exactly the same now with pharmacists, so say with social prescribers, with physios, with physician associates and with paramedics. And the reason is because, one, pragmatically, we can get those staff when we have lots of shortages overall across the NHS of nurses and GPs. We clearly want to grow more of both of those groups as well. And secondly, because we see great opportunity for task substitution. So that we change the blend of what the GP does as the expert generalist, coordinating a bigger core multidisciplinary team that they then own. And we see big opportunities to do that. For example, musculoskeletal care. Actually, the proportion of appointments that can be seen by a physiotherapist is pretty well documented now. We haven't gone for staff from mental health trusts. That's a conscious decision at this stage, partly because our efforts to get the integration right between primary and mental and community-based mental health have been probably harder than some of the other community-based services. I'm not quite sure what it is, some of the cultural and practical issues to try and get that right. But it is a both and. We are also then, as I say, trying to really force as well as encourage, and we don't underestimate the challenges of different tribes talking to each other and building services, the relationships and the trust. There's a lot of skepticism and concern on both sides. You know, primary care, you're trying to steal our staff, or community services, to what extent they're trying to take us over. I'm sure those debates get played out in other countries as well. And that just takes time. But the one other area I wanted to flag is that rather than just thinking about the bulking up of core primary care or the integration with other community health services, is the connection with wider community assets. And that's an area where we are making good progress. I mentioned social prescribing as one obvious case. We have a strong tradition in British general practice that is at least as much psychosocial, I would say, as biomedical. And we'll expect to have 5,000 social prescribers actually working in core general practice, referring people to housing, employment support, bereavement, loneliness, parkrun. We have 1,400 now GP practice, 20%, that refer people to parkrun, which is a free 5K run every Saturday morning, and staff will often take part as well. And that is really flying. It's got a kind of social movement behind it, a real energy.
That's great. Jane.
Well, thank you. I think my colleagues have really described well that our successes, I think, that we've all been finding are in those networks, the groupings of primary care teams, and making sure that they're highly interprofessional. And I really loved Juliet's description of the warm handover, which I think many of us who are primary care physicians, can remember doing many times. And it really is when you walk your patient down the hall to see either the pharmacist or the social worker that that the importance of that handover is understood by our interprofessional colleagues. I think the trick becomes when you go from that geographically co-located interprofessional primary care team, and you have to network on one side into the home and community and on the other side into the hospital, and that's where we fall down. But Canada, having criticized it a little bit, we pride ourselves in having marvelous pilot projects all over the country, and we just have a challenge, as I suspect many of you do as well, to scale and spread those fantastic pilot projects. But we do have, I think, some great examples of when the medical record is shared. That's when we find success. So I, for example, had the privilege of being involved in a project with community paramedics doing the home care delivery. And Ian referred to the role of community paramedicine, which we are seeing some real opportunities in Canada. And our community paramedics would access the very same patient electronic medical record as the physicians would in the office. And the wonderful thing that happens in that case is that you're not necessarily doing that warm physical handover, but as you're sitting taking care of a patient in front of you and the community paramedic is seeing another one of your patients at home, they can actually instant message you live time. So I would be caring for someone in front of me, pause for a moment and say, "Excuse me, I just got a message about an urgent situation I have to address with one of my patients at home," and I can quickly respond back and adjust the medication either by phone or through instant messaging within the same medical record. Everyone knows what's going on, and when we do that, our patients benefit. The challenge is that it's rare that same medical record that the primary care team is using is accessible when the patient walks into the emergency department in Canada. And if any of you have really figured that piece out well, do let us know.
Great, thank you. Catherine?
If I can say something about France, I would say that we are facing double wards, a lot of double wards, two different sectors, private and public sector, ambulatory and hospital sector, health and social sector, and I can add mental health and physical health. And the ambulatory care is an important. The ambulatory care and an important part of institutional care are private and have not the same regulation rules. So one major issue is to create cooperation incentives around patients. I think we have particularly a problem of culture, medical culture in France, to share information and to align financial rules with this objective of cooperation. And that's why that's one issue of the new plan, to change financial rules and to integrate quality objectives for patient outcomes in the system. Yes. Thank you.
That's great. So that leads me to probably the last question that I'll get to ask, which has to do with measuring outcomes and what the goals are. In the U.S., we of course heard reference to the move to value. A number of you have talked about incentives, as Catherine, you just did. The question then is, incentives for what? We have a strong evidence base that strong primary care and primary care-led system leads to better health outcomes. We know that meeting social needs leads to better health outcomes, but these are very long chains of causation, and each part of the chain is under a different actor's control. So my question is, as you are thinking in your country about this move, whether it's primarily regulatory or primarily financial incentive or a combination of the two, what outcomes are you looking for? If it's referrals, is it how many, or is it whether the need was met? If it's some of the questionnaire questions are really process questions. Are those what patients say they want? There was some discussion of giving patients budgets. Then how do you know what their interests are? So I'm just trying to capture a little flavor across your 4 countries in the sense of, as you are trying to improve, what are you measuring improvement against? And you can go right down the list again, or however order. I don't mean to make it so formulaic.
So for New Zealand, our markers of success will always, first and foremost, be around equity. We have substantial disparities in terms of both patient outcomes and in access to care according to socioeconomic group and according to ethnicity, and they are our primary priorities is to reduce these inequities. So for me, success looks like unmet, reductions in unmet need. So unmet need for primary care, our greatest factors are actually around the ability to access an appointment within 48 hours. Then it would be around the ability to pay for the appointment, and then it would be around how life gets in the way, so transport, childcare, those issues. So success in primary care access would be what those markers look like. But then I think it's important to always think about the wider health system. So success looks like, how do we all work together, not only in outcomes, but in the process of care delivery. And again, there are disparities in how we deliver care and accordingly in outcomes for patients according to those different groups. So that's what we'll be using to measure success.
Great, thank you. Who else wants to weigh in?
So let me give you a couple of examples. So one is, I mentioned care homes. Nursing and residential care homes. Some of our most vulnerable patients. We have just under 1% of the population, 0.5%, but a bit more than that in England, in care homes. And we have pretty poor quality care, very variable primary care engagement, and different agencies going in, often relatively poorly qualified staff in those care homes. When we're thinking about what care coordination could look like, proactive care coordination, we're looking at a series of different metrics, including utilization metrics for the wider system, as well as quality of life metrics. Specifically on the utilization metrics, we ran a big pilot in 6 areas, which showed that for over a 3-year period, the rest of the country, not including these areas, had something like a 12% increase in emergency admissions from care homes when they weren't running the interventions that were in the pilot, and it was more like 5% in the pilot areas. So a hugely statistically significant reduction in emergency admissions, but also in ambulance conveyances, and in prescribing costs, and in avoidable mortality. Because if you look at things like what is the biggest cause of avoidable mortality in care homes, it's basically fractured neck of femur, and that's mainly caused by falls. And the primary driver of falls in the care homes is contraindicated polypharmacy. And actually, just having pharmacists go in regularly, particularly when people have gone in for a particular episode into hospital to do the medication reviews, has been highly effective in achieving those effects. So I think there's a lot of very specific metrics that we can all gun after that are win-wins, because it's relatively low cost to have those kind of interventions.
Thank you. That's a great question. I think in Canada, we've certainly seen, I would say, in the last generation that we know we can move outcomes based on incentives. So, I look at things like fecal occult blood testing, pap smears, mammograms, et cetera, and most Canadian physicians are incentivized to a certain extent to make sure that they have a certain proportion of their population that have reached those goals, and that has driven change without question. But the better part of your question is that what patients want? So we know that we can get we can get thousands of physicians to do better at doing the right screening tests. But what we haven't quite figured out is how we can put those incentives and outcome measures in the hands of the patients, so that patients, in part, take responsibility for their own care when they can do so, but that they are also seeing that care is driving into the priorities that they would put in place. And so I think one of the areas where we are still struggling in Canada is how we make clinicians recognize their responsibility around population health. Most of us were trained in systems where population health was not considered to be one of the core competencies of what a physician provider had to deal with. We know how to make our individual patient in front of us well, but what is my obligation to make sure that the population health measures are there? So in Canada, and varies from province to province, but we are starting to see better ways to be able to capture that obligation around population health for physicians. But I think that the key lies in terms of somehow making sure that a larger percentage of our clinician population recognizes that they have a responsibility to care not just for those who happen to cross the doorway and get into their clinical setting, but for those who never get to the clinical setting in the first place. And as policymakers, when I put on my policymaker hat, I'm still puzzled by what is the way to incentivize the obligation of physicians to care for those who never find their ways in front of them.
Yes, some words to give sense to our regulation in France. This sense is really important because we need to convince professionals. That's a really important issue because they are really resisting to this type of transparency, and because that is what patients want, we develop a model based on patient experience and patient outcomes, even patient-reported outcomes, and we experiment innovative payment to promote cooperation as bundled payments with specific quality measures. But now, what is already in the current regulation is just quality incentives of each provider, and what is and the evolution is from process results to outcomes results.
Can you say a little more about what the outcome? The new outcomes,
yeah. We speak about mortality, specific mortalities, and about rehospitalization. That's the two most important indicators we want to develop now.
Great, thank you. Okay, I think I can fit a question or two in from folks out here. Let's come here, and then we'll probably head ourselves to a break. If you could wait for the microphone.
Good morning. My name is Hala. Thank you for the information that you shared with us here. My question is, like Charles mentioned, that we have a problem with the anti-kick and Stark law and the HIPAA for sharing and communication. Do you all have this issue in your countries? Do you have?
Yeah. So let me, it's a great question. So Charles did do a little bit more on Stark and anti-kickback. I mean, and HIPAA and Part 2. So the HIPAA and Part 2 really have to do with the permission you need to exchange information. Always, if you have patient consent, you can, but it can be hard to achieve, and it's very technically onerous to adhere to those. The financial regulations are very much, as he indicated, designed to prevent self-referral. So you can't send a patient to somewhere that you have a financial interest in them getting care. These are very U.S.-specific laws, but the issues of confidentiality and self-dealing are global, and I think if you can reflect on how those play out, that would be very helpful.
So the dealing is not a significant issue in New Zealand because those sort of incentives or financial incentives are largely not present in terms of referral between primary and secondary or specialists. The privacy issue is really interesting, particularly around data privacy. So at present, that's not a significant barrier for sharing health information between clinicians. There's two big issues that we're working through in relation to that. The first is around secondary use of that data. That's what we are really trying to consider with using a framework around social license and integration of multiple data sets at both at a national level. We actually have large numbers of national data sets that cross the sectors. So we have health, social, financial data sets that are all able to be linked. We have a mechanism that we can do so through Statistics New Zealand. And we also have a national health identifier, so each person's health journey is able to be linked. But we don't have primary care data because of our segregated system. We're working on that. Hopefully it'll be imminent. But the second aspect around that is Māori data sovereignty. So our Indigenous population are Māori, and we have a treaty, which is our founding document in New Zealand. So nationally, there are multiple conversations going on about how we use data in a way that both meets Māori expectations and rights and privacy issues, but also ensures that the potential for gain from the integration of data is available and is not locked away, so that there is equal ability for health benefit. So those are our two main issues, none of which are really in legislation, but are more in policy discussions and national conversations at the moment.
In England, the self-dealing issue similarly doesn't really arise in the same way, and we don't have the financial incentives, and indeed we've been through different forms of commissioning. We've been exemplifying the opportunity cost for primary care physicians of the consequences of higher costs elsewhere in the system, and I think that's partly one of the reasons why we have one of the highest level of generic drug prescribing levels in the world, as well as a pretty high sense of understanding of the costs of referral into secondary care. The one specific, I think, where that's not true and hasn't been looked at for many, many years is we have a particular cohort of GPs called dispensing doctors who are mainly in rural areas, and they are involved in both dispensing medicines as well as writing the prescriptions. And there's some interesting new research that's beginning to come out on that particular area. On the patient records side, I think most countries find this hard, technically but also legally. That said, I think we are making pretty good progress, and I can point to quite a lot of parts of the English NHS now that have fully integrated health data sets across primary, community and acute and wider social care settings. Probably the weakest bit of this is what we call community health services in England. And that means we're able to engage much more in some of the population health management work. Actually, run the algorithms on greatest likely predictive utilization, who we should be targeting for proactive anticipatory care. So we're making pretty good progress, though it's slow and difficult.
Well, thank you for the question. In Canada, again, we have, I think the self-dealing issue isn't as significant, but we have had, there are progressive changes sometimes in our billing codes that have tried to disincentivize and address that particular issue. But like the others, I'll talk a little bit more around the privacy piece. And I should point out that there are experts in the room, including my colleagues at Canada Health InfoA and the Canadian Institutes for Health Information, who know far more about this than I. So, I have to be careful that I don't say anything that's incorrect, because they are much more familiar with the broad picture. But one of the interesting things that Juliet brought up, which I found was a good learning for me in recent years, around our prioritization around privacy and how it actually sets barriers for us. Part of my time in the federal government was as Minister of Indigenous Services, with responsibility around addressing socioeconomic gaps for First Nations, Inuit and Métis Canadians. And one of their real challenges was the fact that we have been so particularly sensitive about addressing ethnic markers in medical records that it actually causes barriers to them getting the kind of health information that would drive governments to actually improve things. So what I learned from First Nations, Inuit and Métis colleagues is that they would rather actually have demographic and socioeconomic and ethnic markers on their health records so that they could more easily prove to us that, in fact, on any number of measures that their health outcomes were much worse. And so we've started to try to explore within the data sovereignty conversation what it looks like to make sure that we are sharing those kinds of pieces of information in an aggregated way to be able to gather the kind of information that would drive change.
I'm not sure to understand everything. I'm sorry. But I think that in France, you spoke about referral. And I think it's a problem in France because there is no interest for a doctor to refer a patient, and it is a real inconvenient because some providers are afraid to lose their patients when they use another specialist. And for the question of data, we are implemented in France an electronic medical record and the share of this at the national level, but it is not a real database. It's just documents which you can share, and it's not useful to measure indicators. So we work more on medical administrative databases to try to improve the collect of data and to measure quality indicators, because I think the electronic medical records we have now in France at the national level is not useful for that. There is initiatives, local initiatives, hospital initiatives, which are useful for that with medical information in databases, but not at the national level.
Okay, thank you. I'm afraid I misjudged time. I'm going to need to call this panel to a close so we can have a little break before our others. Please join me in thanking these terrific presenters.
But you were... when did you...
Okay, we're going to restart with our second panel.
Okay.
The focus of this panel will be on the integration of health and social care, as was noted in the questions at the outset. How people define and think of social care and what the social care systems are is highly variable across countries, and that's a theme I know you will hear more about in the next hour. You'll be hearing from Tobias Esch, a primary care physician, health researcher, neuroscientist, former Harkness Fellow, professor of integrative primary health care at Wittenherdecke University and in Germany, dean for organizational development and professor of integrative health care at the School of Medicine there. Ann Greiner, President and Chief Executive Officer of the newly renamed Primary Care Collaborative, formerly the Patient-Centered Primary Care Collaborative, and was the Vice President of Public Affairs at the National Quality Forum, has worked at the National Academies of Medicine as well. Martin Roland, Emeritus Professor of Health Services Research at the University of Cambridge with a strong professional background in general practice and health services research. Onil Bhattacharyya, Friggin-Blau Chair in Family Medicine Research at Women's College Hospital, and a practicing clinician, associate professor in the Department of Family and Community Medicine and the Institute of Health Policy, University of Toronto. So you'll get, again, 4 different perspectives on this topic from 4 different countries, and we've asked our panelists to spend up to 5 minutes giving a sense of this issue. I'll begin with Tobias.
Yeah, thanks, Alan. Thank you for having me. It's a great pleasure here as a Harkness Fellow and also as a primary care physician trying to help reshaping primary care in Germany, which is really an issue. And to have the support of this community with the data to see that we're not alone. So let me start with some very short remarks on the survey as a whole, and then I will come to the issue of social care. From the German perspective, since Germany was mentioned a couple of times, do the results of the survey make sense? Of course, from the German perspective, certainly. But there are some areas where Germany kind of sticks out in the good and the bad ways, and so I want to focus just like 2 minutes on 5 points, and social care is one of it. We talked about home visits, and Germany was among those countries which scored pretty high, almost 100% of the primary care physicians offering home visits. However, I have to say, is this sustainable? No, it's not. And the German physicians, honestly, are not. Many of them are not really happy about the way it is now, because there's a huge disruption on their workflows. It costs a lot of money and is not as reimbursed as it should be. So, is it sustainable? No. The enthusiasm about home visits is certainly going down in Germany. And the solution may be physician assistants or other providers going into the gap between the primary care physicians and the patients. So this is what happens in this country, in the US, I know, and many countries, and the same is true in Germany. So I guess we will, from both sides, meet in the middle somewhere. Then, when it comes to after-hour care, again, Germany ranking pretty high here. That is true. That's a good thing. That's by law in Germany. We have a law saying that it's a service guarantee, a guaranteed access 24/7 to primary care. That's the good part. The bad part is that we actually have 2 ways to access healthcare in Germany, primary care. One is in Germany also the emergency department, ED, and the other is the 24/7 guaranteed access to primary care. And I have to admit that the patient steers this process, and many patients end up going to the ED in Germany too. So it's not that there's just one door and patients go into the service guaranteed by law, primary care, but many go even to both or to emergency departments. So that's a good thing, but certainly there should be one access route to primary care. The third thing is about, and that is something really embarrassing for Germany, I have to say, Germany ranking last place in all domains when it comes to specialist care coordination. There's really a lack of coordination and communication, either the primary care physician not sending any information when he sends a he or she sends a patient to the specialist, and only in 11% receiving information from the specialist. And it's pretty embarrassing acknowledging that when specialist changes medication, for example, which they regularly do, there's no communication back to the primary care physician. How can that be in these times? So I have to say there's a big problem in Germany. Fourth point, health information technology. All of us, we could see on the charts, have a big issue here, a big challenge, challenge in front of us. However, there are some countries working better than others, and you saw sometimes zero on the Germany here on the charts. So in Germany, we really just entered the phase of acknowledging electronic health record and health information technology for a way to communicate with patients. That just started. And it's very, very... so lab results, you cannot see your lab results online. In our place where I work, we do, but this is why I was a Harkness Fellow. I brought all this to this place where I work, but that's the only place in Germany where patients could actually see their lab results or open notes. Physician notes, our patients in the place where I work can use them, but that's the only place in Germany. So there's a long way to go. When it comes to social care, what I learned from going through the data and discussing is, yes, there are very different definitions of social care in many countries. So in Germany, it's not about housing, it's not about shelter, it's not about transport or food supply, it's not about unmet social health needs. It's simply about paperwork. Germany, social care coordination means doctors filling in paperwork for handicap pass, for this degree of disability, employability, loss of earning capacities, guardianship issues. It's really about paperwork. So when the issue or the survey says 74% of German primary care physicians reporting they are coordinating, and we are ranked first place here, I have to admit this is not really bidirectional communication. This is simply paperwork, not providing actually social care. So there's a long way to go. And reimbursement was a question. Doctors get money for filling out the paperwork, so it's interesting for them to do this. So reimbursement certainly is an issue, and I have to say, yes, why not? I mean, I'm also with my other profession, a neuroscientist, doing research on the reward and motivation system, and money is one point to reward people, and that's for sure for primary care. But there are many other ways, and the warm hand over, the relationship. All this is another part of it. So social care also, I have to admit, is something that we could certainly improve. So my conclusion, great potential in many areas that I just listed, and maybe to make it very short, please add the patient in future surveys and the patient experience. It's completely missing, and we should add it. The experience with primary care, that should be a domain. And that was one question. Physician or healthcare provider satisfaction with work is also a very important thing. These two, please add in the future. Thank you.
Thank you. Anne.
Thanks so much, and thanks so much for the invitation to be here. I'm thrilled. First, I'd like to start off by saying that I think the focus of the study is exactly right, because care coordination is so important to the outcomes that we want to achieve, both across the health system and between social care and health care. But it's also really important to patients. To your point, Tobias, a study in Health Affairs in 2010 that Deborah Ness did from the National Partnership for Women and Families, of focus groups of patients and then a follow-up survey. When they were asked, what do you want from primary care, they said, coordination and communication. So I think this really is about how do we change our healthcare system to really meet patient needs. I also was thrilled to see something positive in this year's survey, because in the past, to be honest, it's been a bit grim. There weren't many positive findings for the U.S., and we see that the U.S. has made some strides in the technology space, and obviously that's very important and a key contributor to coordination. We obviously need the workforce to be working with each other, and there's a lot to do to focus on the changes in preparation for the workforce and culture and norms and work redesign, etc. We have to get the payment right, but then technology is huge. And so I feel somewhat optimistic that the U.S. is making some of those strides, and hopefully that will help to facilitate some of the coordination that we all hope to see. Because we do need to do quite a lot of work there, both across the healthcare system, but then between the medical system and the social care system. And with respect to the social care system in the U.S., that's also challenging, because if we think that the health system doesn't have the data and IT infrastructure to function well, in the U.S. that's also true, and even more so in the social care system. So we've got, two different tribes, but also different capacity with respect to data and infrastructure. So lots of challenges. When the organization that I now lead first came up with a vision for how they wanted to reinvent primary care, social determinants wasn't even in it, and that was in 2007. The notion was really focused on risk adjustment related to clinical issues, not to social. And then 10 years later, when we updated the principles, social determinants was very much a part of the fabric. So I think that's very exciting that we now have this focus, and now we have to figure out how do we change payment and who does what. It's a little bit confusing in this country about the various roles of the medical system versus the social care system. So lots to sort out. But we also have, I think, a fundamental disconnect in our country. And if you look at some of the OECD data about what various high-income countries spend on social care versus medical care, the U.S. also is a huge outlier. So, we spend about 2-to-1 health care versus social care, and most of the European countries, it's the reverse, or it's more equitable. So our social care system is so under-resourced, so it's not a surprise that we have all of these social issues that are unmet. And in addition, in this country, we also underinvest in primary care. So exactly the sort of things that could help address these social risk issues, we dramatically underinvest in this country. And in terms of primary care, we're at about 6% of total healthcare spend in primary care, and the OECD countries average 14, and some are as high as 19. So we've got some important work to do to shift dollars to where we really can contribute ultimately to the population health outcomes we want to see, better equity, and yes, affordability. And of course, this underinvestment creates this double whammy in that we're spending all of our money downstream in hospitals and specialty care, and our system is so expensive. Looking at the data in the study related to social care, I was actually surprised that the U.S. did as well as it did, to be honest. And I wondered if we have different conceptions of integration. Like I was wondering if an American physician might think if you just did the WIC referral, that was, a great integration with the social care system. And maybe the European doctors thought if you took care of daycare, drug and alcohol conditions, and housing, that would be comprehensive. I don't know, but it would be wonderful to do some interviews and really try to understand that. And then I guess I want to close with a little bit of optimism, because I think U.S. policymakers, both public and private, do understand how much The lack of addressing social issues contributes to high costs and poor population outcomes, and the federal government is taking a lot of steps through CMS, changes to regulation to allow Medicare Advantage plans, for example, to start providing support for social services through the Centers for Medicare and Medicaid Innovation. Health plans are also stepping up to the plate, Kaiser Permanente, Humana, et cetera. They're really trying to address these set of issues, which are challenging, but at least they're now recognized, and perhaps we're making some slow progress. Thank you.
Thank you, Anne.
Right. Thank you. First, thank you to the Commonwealth Fund for asking me to come. I've hugely enjoyed my interaction with the fund over many years. One of the failings I regard in my own career is never having actually managed to be a Harkness Fellow. But I've kind of made up for it by sending Robin, well, I must be a good half dozen fellows from departments that I've led over the years. So I've done my bit in that sense. I'm going to talk a bit about social care, and because that's all rather depressing, I'll end up with 3 positive examples of things we might do from the UK. As we've heard, social care means different things to different people. And for me in the UK, social care largely means, and it's sometimes called personal care, care provided to older or disabled folk at home, including things like getting up, washing, dressing, help with eating, and places in nursing homes. And this sector is under huge strain at the moment, being squeezed from 2 directions: an increasing number of very older people, and the funders, who are principally local authorities or municipalities in the UK, having had their budgets cut, so more need, less money. And this has 2 direct impacts on the healthcare system. First, it leads primary care physicians to admit sick people to hospital who might have been able to be looked after at home while they were unwell with a bit more care. And it also leads to so-called bed blocking in hospitals, i.e. people who are medically fit to go home, but they can't do so without additional social support. And these can account for up to 10% of patient hospital inpatients. And there's a huge political debate in our country at the moment as to who should pay for this, with the increasing elderly population. And the tension is between the left, who offer a welfare state-type social contract in which personal care would essentially be free in the way that healthcare is, and our right, well, obviously our right's a long way left of your right, who are not quite sure. And we have a general election. We have a general election in 2 days' time, indeed, in which the Labour Party are essentially offering more or less free social care to everybody, and the Conservative Party who are saying it's jolly difficult. If we come on to the results of this survey, one in which we look really good with Germany, unfortunately we're probably not quite as good, because 65% of our respondents said, yeah, they could frequently coordinate with social services or other community providers. And I think there may have been a problem with that question, because other community providers could well be people with whom GPs regularly communicate. They're district nurses, midwives, health visitors, other people working in the community. I suspect if the question had been restricted to social care only, it would have been less than 5%, because the truth is we have huge problems in coordinating with social care. And I think that that's reflected maybe in the last question in terms of follow-up from social services organisations, where we come bottom of the league. And part of there have been a number of initiatives to try and bring health and social care together over the years, but they do come from very culturally different places, and it's proved extraordinarily difficult, not just an issue of merging budgets, but an issue of merging cultures. So as not to be too gloomy, let me give you 3 kind of positive ideas, things that might get better outcomes in terms of better care at reduced cost, the Holy Grail. I mean, I'm aware that sort of grand policy ideas often kind of look like they're giving a GPS device with accurate positioning of icebergs to the Titanic's captain, and turns out it's just rearranging the deck chairs on the passenger deck. But nevertheless, we think that we are probably hugely wasteful in the way that primary and secondary care communicate with each other. And there's some very interesting experience going on in East London at the moment, where instead of the normal system, which is me as a primary care physician, sees a patient, thinks they need to see a specialist, writes a letter, may go electronically, goes to the hospital, sits in a pallet, gets to the top, and the specialist sees the patient some weeks later. What they're trialling with significant success is, I write to the specialist, he immediately takes responsibility for that referral and does something. He might phone the patient, He might have a video consultation with the patient. He might phone me and suggest something else. He might arrange an investigation. And as a last resort, he'll see the patient in his clinic. And that is a transformative way of those two parts of the healthcare sector working together. Secondly, Ian has already mentioned the initiatives that we've got with nursing homes, where there is huge opportunities for improving care and avoiding old people being sent to the ER in the middle of the night unnecessarily because there hasn't been a proper plan made and the person who was looking after them was underqualified and didn't know there was a plan, even if there was one. So pharmacists doing reviews, general practice getting better organised. So quite often a care home will have physicians from 4 or 5 practices visiting their patients, which is nonsense. In some parts of the country, the practices have got together and said, actually, we'll look after that home, and you can look after that home, and you can look after that one, giving much better opportunity for proactive care and not always being on the back reactive foot. So I think that has an opportunity to provide better care at reduced cost. And the third one is that Ian also mentioned social prescribing. So this is giving GPs resources, i.e. link workers in their practices, to help with things like in being able to send patients to local groups, self-help groups, art classes, dance activities, funding gym membership. Really good idea. My prediction is highly, highly unlikely to save any money. It's a number of really good ideas that we produce in the NHS that people think will save money. They improve care. They're very popular with patients. My prediction, it won't save money, but it probably won't cost a lot more either. Thank you.
All right. Thank you very much for the invitation to speak today. As a former Harkness Fellow, it feels like I'm coming home again. So for the Commonwealth Fund Survey, every time it comes out in Canada, it's really an opportunity for us to work on our humility because generally our access to primary care is consistently worse than other regions. This was again highlighted in the lack of arrangements for after-hours care, where we ranked second last, thankfully above the U.S. However, it's refreshing to see we're only middling in the area of care coordination. Within primary care, care coordination is seen as important, but variable efforts really been put into it. Like other regions, 42% of providers lack the staff to do it well. And despite the fact that there's a single payer in Canada, everyone is paid separately. So there's no accountability, not only are they paid separately, there's no accountability for the results you get, and there's no reciprocal responsibility between providers. So there's an opportunity there that really hasn't been leveraged historically. And government hasn't invested in infrastructure to make it easy. Each sector has different systems which are not interoperable. In some regions, government has invested in clinical viewers that allow some institutions to see some results, but few have mechanisms for sharing information electronically, as you saw in the survey. We're outliers with respect to the use of IT systems for patients to access and coordinate care. This might be in part because our major investments in primary care electronic medical records are just over a decade old and we haven't fully realized their potential. And this is sometimes because the functions are not included in our current electronic medical records, but more often the function exists but hasn't been turned on or it's not well developed, like messaging with patients or video visits. Patient demand for the 4 functions that were highlighted in the survey is very high, and yet only 1% of Canadian practices offer them. One reason is that in a model that's predominantly fee-for-service or blended capitation, there's only 2 provinces in the country that allow billing for video visits. And the other relates to what GPs think their job is. I've done a series of studies on virtual visits in primary care, care coordination platforms, and remote monitoring. And the uptake from primary care actually has been very modest. In one instance, we were doing remote monitoring for COPD. We had a bunch of different services at the table, and the chief of primary care in a particular hospital said, "This is not our job. We don't do this," right? So it's a real shift, and part of it is that if primary care is a high-throughput, low-margin business led by independent providers who build a government, then these aren't core. I think of these things as building blocks for digital building blocks for modern primary care, because virtual visits improve access. Care coordination platforms are core, obviously, to care coordination, not just sharing information, but also developing coordinated plans, updating those plans, and negotiating across the various providers to achieve goal-centered care. And the third one, obviously, remote monitoring would allow for people to get the same set of information to make the same set of decisions around a patient evolving. And in primary care, it's really important because most of the things we do only have a 10% effect size. So if you're not tracking these things, you actually don't know even what's working. So on one hand, if you're just an independent, small businessman or independent small business, these are not the building blocks for primary care. But if primary care is the entry point to an integrated delivery system, then they would be crucial. That's just not how our system's set up. However, there's hope for change. Like Martin, I am, an optimist. In the province of Alberta, they've recently set up strategic clinical networks that relate to some of the work that we've seen in other regions where primary care is organizing at a higher level. And they're currently implementing the EPIC electronic medical system across the entire province. So there will be an opportunity for seamless communication. A lot of the functions where you saw us, not performing will become effortless once that's complete. In Ontario, in the province where I live, we just completed a pilot of virtual visits that include billing codes for both text and video. We recruited 200 doctors, had 14,000 patients, and conducted 14,000 visits over a 6-month period. From the ministry side, they were happy because it didn't dramatically increase cost. It wasn't overused. From the provider side, it wasn't a massive increase in workload. And so they're now expanding that pilot to roll out first video and then hopefully text. In terms of the coordination at the core, the job of primary care, we have now a new reform in Ontario called the Ontario Health Team Model. It's loosely modeled off of accountable care organizations where primary care, community services, and hospitals in a region get together, will be accountable for a defined population, and actually have to build a digital front door, provide 24/7 access to a wide range of services, and eventually move towards a value-based type funding model. So this was just proposed last year, and they're just starting. So your survey is extremely timely because it gives us a baseline before a massive health reform, and hopefully an opportunity to see us move up in the league tables. Thank you.
These are a great starting point, and I am going to try, although I appreciated the references to the broader survey, to keep a little bit tighter focus on the integration topic. So I'm going to start with some things that I don't think we need to spend a lot of time on. It has been noted that social care means different things to different people. It may mean different things in different countries. I appreciated Anne's comment that integration may mean different things to different people. And I was struck, Martin, that to you the prototype was care for older adults. I think that when we talk about it in the U.S., that's not the only population we're focused on. So lots of heterogeneity in the concept. That's one thing I think we can agree on. And the second that we can agree on is that no one does this particularly well. And there are reasons for it, but I'd say it starts in the fact that we have long traditions of separate systems, and all of us who are trying to do it are trying to re-engineer fully entrenched systems. So let's all be okay with the fact that we're not exactly sure what we're talking about, and we know we don't do it very well. But there's surprising confluence that we're trying to do it better. And so I think that's the place from which I'd like to depart in thinking about the ideas for going forward. So I really want to focus for a moment on Onil, where you ended, on accountability and where it lies. And I also want to bring in another potential source of accountability, which seems to me we don't talk a lot about. Maybe it's because we're not in it, but we're often talking about social outcomes, but we're all talking about where's the accountability within the healthcare system. So one of my questions is, what do we know about the accountability in the social care systems that we ought to be working with? Otherwise, we're trying to solve someone else's problem without even understanding how they approach the problem. So can we just, and this is a little bit of continuity from the question I asked the first panel, but I just wonder if each of you could go a little bit deeper in your sense of where you, taking again the uncertainties and challenges that as a given, where do you see the accountability today? Do you see change in where in the political discourse or in the health sector discourse about where accountability should rest? And if so, give us a sense of that direction. I'm just sort of trying to get some building blocks here. And we don't have to go straight down the row if we don't want to. So Onil, you teed something up right at the end. Maybe you want to go a little deeper on
Sure.
that, and we'll take it.
Sure. So, within the organization, so if we think of the three sectors of primary care, community services, and hospitals, they, have some accountability. They're accountable to the payer, which is, one entity, but they collect a series of metrics that relate often to productivity. They are not accountable to each other in any way. And I think that's one important thing, because to achieve outcomes, and a lot of what they report on is process, but to achieve better outcomes, they've got to work together. Some of the structures, I just mentioned this Ontario Health Team concept, these integrated delivery systems, and we're thinking about 300,000 to 500,000 people in a region as a kind of unit that they're collectively accountable for. It's the opportunity for these groups to get together and say, okay, what are you measuring, what are you doing, and how can we improve those outcomes? So that's it. We're at the beginning of that process, and we're developing a series of patient-reported outcome and experience measures, in addition to measures, obviously 30-day, 60-day, 90-day readmissions relate to multiple sectors. And then there's issues around access. So a lot of the things you saw in this survey are things that will be at the core of defining a different type of accountability. But the current one is different sectors accountable for a small set of metrics that actually are hard for them to budge, and with one payer. In primary care, there is minimal accountability. You get random audits, you can't bill too much, but that's essentially it. So primary care is extremely independent in Canada. We're publicly paid private providers who are we don't even work for the hospital. We are independent contractors that have rights within a hospital. So it's a big step.
Great.
So it's probably slightly worse than you suggest, in that they're not accountable to each other, but the accountabilities may sometimes actively conflict. So if a local authority, if what's needed in a particular city is for a local authority to provide more care home places for people who are in hospital, medically fit to go home but need some more looking after until they're ready to go home. So the local authority could build such a facility, and it would cost it money, and it would save the health service money. And there's no transfer between those two. There is, I believe, one hospital in the UK where they have actually purchased their own care home facility to do precisely that. I'm not sure Ian would tell us if they're actually allowed to do that or not. I'm not sure. And so there's a big divide with funding, and we have one big experiment in the UK, which is called Devolution in Manchester, where the social and healthcare budgets have been merged. So the organisations and the budgets have been merged, and this clearly makes huge sense. And we're 3 years in, and it's probably too early to tell. There certainly hasn't been a dramatic effect, and one of the things that would speak to is that any of these sorts of changes take a long time, particularly if they require significant cultural change. They require people to take on different roles. They might need people to take on different employers. These things take a long time to bed in. And politicians, not obviously policymakers within in the room, but politicians are much too impatient in our country. And the thought that you might need to let something run for 3 to 5 years before you really knew whether it was working, well, that might be 1 or 2 governments on. Or 3 or 4 at the present rate.
I guess for accountability, you need, across the healthcare system, because that's really what we're focused on right now in the U.S. You need alignment of measures, which we're working on, but we have a long ways to go. And I think you need alignment of incentives, and that's where we're really, we're working at cross purposes often. So if primary care is adequately doing its job and helping to manage patients, they're not going to the ED and they're not going to the hospital. But now, increasingly, and a majority of physicians are now working for the hospital. So if they do a good job, the CFO in the hospital is unhappy, because that has just meant a revenue loss for the hospital. So, we've really, in our country, need to get these incentives aligned, because they're working at cross purposes. Accountable care organizations are one attempt to get those incentives aligned. There's some promise there, but we have much work to do. the Centers for Medicare and Medicaid Innovation is also working to try to bring in the community piece, and so they have a model called Accountable Health Communities. It's a 5-year experimentation, early stages, and mostly it's focused on screen and refer, and so, you know, it's the beginning. So in our country, we're not as far along as I think in the nowhere near as far along as you are in the UK with really thinking about social prescribing, really thinking about how do you integrate community-based organizations, how do you merge budgets? Wow, that's really interesting, and it would be wonderful if we could innovate in that way.
Thank you. One short note on before I come to accountability on the fact that we have different definitions, or don't really know which definitions we have on social care and integration, and not doing well. So the good thing here is that because there's a big area of improvement, we can learn from others. So what I think is so important on conferences like here and other places, that we talk to each other and learn from areas where it works well, and then from there maybe start defining what is the best way to do it. Not starting off, obviously defining is not solving the issue, but maybe seeing what works well, and then from there on defining what we actually want. When it comes to accountability, well, in Germany, at least at this point, clearly it's in the hand of the social services. They're accountable, they're held accountable, and so it's public health, which is a big problem. We learned here, I heard it here, and I would agree that should move down to community and maybe even to the primary care physician or the primary care world. We heard from Jane that doctors should care more about not the individual patients but the community around their practice, and in primary care would definitely agree that population health is an issue of primary care. However, this does only work in an integrated system. For example, we created a position in our primary care clinic in Germany, which is called is called a social coordinator. She's there full time to do actually integration or do social care coordination. But since the system is not set up in a way where we can provide some of these issues, it ends up again being paperwork. So that's not solving the problem. We have to we have to find ways to move these issues really down the line into the community and the primary care setting, so that really we can provide such care. So in the future, I heard in the earlier panel one suggestion that I found fascinating is patient-based budgets. So giving the patient at least a little bit power to decide where the money goes. I think that's a very interesting path to follow. Before that, accountable care organization is certainly valuable. We do this, that we get money per patient, and we try to do the best, including social care, as I said. So that's a way, accountable care organization, but maybe even going one step further and having patients decide where the money goes. That's a piece of the money goes. That would be a very interesting road to follow.
Great. Martin, I'm glad you brought up the dimension of time. It's not just politicians who are anxious for results, and if we're building new models and we're trying to figure out if they work, even researchers want to know quickly whether or not something works. As we have the conversation about social care, there's a continuum, everything from someone who doesn't have stable housing, who, if you solve that problem, you can see quite quickly some improvements in care with potentially long downstream benefits. But if you get to deeper issues of education, income, employment, you might have a much longer investment with a very different tail. As each of you all, and again, acknowledging that we're all in different places, are thinking about the imperative for improvement, but also the desire for quick results. Can you reflect on the time horizon of the intervention as well as the expected or hoped for results from those interventions? Any thoughts?
Well, just to start, I mean, that's a complex issue. But to start with, I guess there are some areas where you can have quick wins because the situation as it is so awful on the one hand. And on the other hand, there's so many creative people out there designing, having ideas and designing how we want to work together, how we want to build up and reorganize our communities. In Germany, for example, we have an initiative called New Start for the health system, including social health. And we bring together patients, we bring together experts for over a process now of 1 year. And we have regular visits coming together. We just had one last week where patients come together with experts, with payers, and discuss how to exactly do this kind of integration. What are the quick wins? What are the ones that need long-term stability and stamina? And we see that there are many things. People have the ideas. Some people have the money. Some people have the brains, the technical issues. I guess some things would work very quick when we get those people together and co-design and come up with solutions. So maybe we should not only talk about time or money reimbursement, but about how organizing this platform where actually people in the community, in the primary care sector, really discuss and talk to each other and come up with solutions.
That's great.
I think this year will be the 4th year for life expectancy to either be flat or depressed in the U.S. After a 100-year, steady uptick, except for world wars. So, I really do think that there's a sense of urgency that we've got to figure out what we need to do differently. Researchers think a lot of this is related to addiction, opiates, but also, other drugs and alcohol. So to me, that's an issue that we should be focused on, and maybe that can have some quicker response. And it obviously is behavioral health, but it also is there's a lot of social issues in that whole realm. And then housing. I mean, I think that's where a lot of the healthcare system is focused. Readmissions penalties was a big spur for the hospitals in our country to start focusing on, okay, what happens when people leave the hospital, because you would get penalized if they come back within 30 days, and it really got hospitals to think about how do we integrate with the health system, but also beyond the health system, social care. So, how can we structure value-based payment to really spur this sort of integration, address some of these issues that are getting in the way of our, the health of our population and contributing to depressed life expectancy?
Well, when you're looking at the outcomes of primary care, you should, on the whole, be looking at process measures rather than outcomes, because outcomes are often very long-term and influenced by loads of other things. And the problem with process measures is that for coordination, we do not have any good measures of coordination. And a number of well-known organisations in the States and in the UK have been trying to develop good measures, and they're just not very good. So we don't have a very good method of measuring coordination, and we don't have good outcomes by which to judge the coordinated care. So we fall back on poor measures. And you measured readmissions. Yeah, well, that is clearly something that policymakers focus on, and maybe they kind of imagine they can all be avoided. We did a systematic review a while ago which suggested that probably around 15% of 30-day readmissions were potentially avoidable, i.e. 85% weren't. Catherine earlier was talking about readmissions and mortality as her two key outcomes. Well, are there many areas where you would look in a specific patient population at reduced mortality within a time frame you could look at? So we're really tied-bound by not knowing really how well our measures of coordination have worked and not having very good measures of the impact of those changes. That's a bit negative, but we need progress in both those areas.
That's great.
I want to build on Martin's comments just now on evaluating things to interventions specifically that target coordination. So in 2012, we worked on a project called Seamless Care, Optimizing the Patient Experience. It was a service for solo primary care docs, so the kind of primary care doc that just has a shingle up front and a secretary. And we gave them a number to call. They could press 1 to speak directly to an internal medicine specialist, 2 to speak to an acute care nurse navigator, 3 to speak to a community service care coordinator, and 4 to speak to a radiologist. And the idea was to facilitate, communication and direct communication to, manage more of their care in the practice. And so we started that, and at the time, avoidable ED visits was the metric of the day. So we did a nice study with a propensity match cohort and demonstrated no impact on ED visits. But this intervention could do a bunch of things. It was really open-ended. You used it for whatever you wanted to. And so we've spent many years refining it and trying to, get interest, and really struggling on saying, where is the impact of this? And it was only recently with this new policy around care integration and access to specialists where suddenly there's enormous interest in this intervention that had been going on for 6 years, and we were having trouble getting people on board. And in the last year, it's gone from 50 to 400 doctors, 7 different regions have built it into their plans, 4 or 5 have already implemented it. But it's almost like it was an idea and the outcome, even though we don't have the outcome yet, people didn't see the value 6 years ago. And now, because of our shift in the way we think, now integrated care is a major strategy, and this is a tool for integrated care, even if we can't measure the outcome. And interestingly, as we've built this out, now we've added mental health services, neurology, and a bunch of other things, and we still don't quite know how it works.
But does it work?
People make calls, the physicians are satisfied, they feel like they get answers to their questions faster. But it's a funny service because it's if you could only see a physician specialist on an inpatient basis, and you suddenly created ambulatory specialty care, how would you measure the impact of that?
That's a great way to think about the time dimension as well, which is that a null finding doesn't mean a null finding forever. It means maybe you're looking at the wrong question or can retool the tool. It's very interesting. We have time for some questions from you all, and don't want to miss this opportunity. Let's see if I can. Yes, let's bring the microphone up to the front if we could.
Thank you very much. We have a series of measures that we call system level measures, and they're designed to assess the success of the entire system working together. And one of them is ambulatory sensitive hospitalisations for children aged under 4. The problem is that what we find is that the most significant drivers of these hospitalisations are things that are within the political remit, not within health or social. And so I'm thinking of fluoridation of water supplies and vaccination, things like that. So they're ultimately quite depressing and demoralising for the health system to be rated against things over which they have little control, even though it's designed to assess how primary care works with secondary care and working with the hospital doctors. I was wondering if you had any suggestions for us on that.
Well, I have a view on ambulatory care sensitive conditions, which unfortunately I've not been able to prove, but it is easily provable if somebody could find the time to do the work. So ambulatory care sensitive conditions, these are the conditions that people don't need to be admitted to hospital for. Asthma, tonsillitis, whatever. Decent primary care, and you wouldn't have to get admitted to hospital. So they're much beloved to policymakers because they look like an easy win. Now, my hunch is that the evidence that improving healthcare reduces ambulatory care sensitive conditions is largely based on relatively old US data where the populations you're looking at are those who do not have a regular source of primary care. And of course, if you give them primary care, they're going to turn up in the ED less frequently. My interpretation of the literature without having looked at it in enormous detail is that when you take countries with established good systems of primary care, as in, say, New Zealand or the UK, then the ability to use ambulatory care sensitive admissions as a marker is much reduced. So I don't know if that's true or not, but if it is, it means that it's a little bit of a false idea that this is a great outcome.
Interesting. Onil, and then Anne.
So just a quick comment. I remember a comment from Jane Philpott when she was health minister, talking about being at a table with all the other ministries and saying, you guys are all in that, to some extent in the Ministry of Health. And how can we work together? And so I think if there's a table where those different groups can get together and work together to improve outcomes for the nation, then there may be an opportunity to coordinate, at that even higher level.
I was just going to say that I had not thought about how the context has such an effect on the measure, because you think, okay, we've got a standardized measure, we can just use it in different countries, but thank you for that insight. The care coordination measures, I was at an NQF meeting last week, and the term that we described care coordination measures was it's like the Bermuda Triangle of performance measurement. Many people go there, nobody comes out, and no measures ever come out. And I think it is one of these holy grails, like you see it on the list of measurement prioritization. How will we know if care is actually integrated and coordinated? What are our measures? And we're still not there yet. And part of it is data systems and the like, but it's also it's very challenging to come up with these measures that actually work.
Well, one of the measures is asking the patients, which, Robin, you've done in previous surveys of patients. And this is not bad measures.
This is exactly what I wanted to add. Because the problem with outcomes of care coordination is that there are so many and so many different. For example, in our primary care clinic, we have the doctors, we have the nurses, we have case managers working, we have, as I said, social coordinators, we call them therapists for health promotion. So different professions working under one roof and actually working with the same patient, and then we talk with each other. We have case conferences every day where all the professions come together and talk about what they learned from the patient. And so we have many different things happening there. We have someone who something is diagnosed that people haven't seen for 20 years because we just talked about with each other. We have patients that are starting to do lifestyle changes that they haven't done before. And then we have patients just going home and telling their husbands or their spouses that they're happy actually that someone took time and listened, and they realize that we talk to each other. So we have now a waiting list. People are running through our place just because patients realize that something is different because these people talk to each other. So we need to ask the patients, we need to look at different medical outcomes and very different measures. But one thing is, if we ask the patient, they will tell you if it works or not. They know.
I'm struck as we finish this conversation that the number of years and the amount of effort we've put into trying to generate and support team-based care from the financing side, the training side, the professional rewards satisfaction side, the institutional side, and we're now in essence trying to do the same thing with social, and we probably are going to need at least as long to do that because, again, we're crossing institutional boundaries, educational boundaries, financial boundaries. And so maybe if we take a dose of reality from the pace of change on team-based clinical care, that's probably a reasonable benchmark for patient-centered care that also addresses social care needs. We are at time. I want to make sure we have time for our closing presenter. So please join me in thanking these panelists. And as they are stepping aside, I want to take a moment to introduce our closing act, who will put the pieces together, as the title says. Noam Levey, Senior Health Policy Reporter for the Los Angeles Times, based here in D.C. I will just say it's hard to think of a journalist who is more able to capture the reality of the lived experience associated with the complex policies that we all debate every day. And I enjoy and learn from Noam's writing, but as I say, what stands out for me most is the ability to understand how these complex policies actually play out for real people. It's a gift, and I've benefited from reading Noam's work. And so with that, I'm really pleased to turn the microphone over to you to give us some closing thoughts. Noam Levey.
Thank you so much for the kind words, and thank you for the invitation to talk to you all. I will be brief because I know I'm standing between you and lunch, but it is really an honor to get a chance to reflect on all of these incredibly thoughtful observations about not only our own healthcare system, but the healthcare systems around the world. I've been working with the Commonwealth Fund now for going on 10 years. And I'm a huge fan of all the work and use it extensively in the reporting that I do. I can say, as a journalist and a print journalist at that, I have a particular admiration for efforts to speak the truth against a storm of social media and online memes about dancing guinea pigs, to say nothing of fake news and such. So it is particularly, I think I have particular admiration for the work, the international work, since the fund is stubbornly over the years tried to direct Americans' attention at lessons that can be learned abroad in the face of determined resistance, unfortunately, by some policymakers who continue to insist that our system cannot be improved. I think as I listen to the discussion about primary care and particularly about social determinants of health at the sort of back to the future notion of so much of this discussion, and if I've learned nothing else covering healthcare for the last 10 years, it is that is perhaps a defining feature of talking about healthcare in this country. But clearly, lessons to be learned abroad about both the importance of primary care and even more so the importance of addressing what we now call social determinants of health are nothing new. In fact, if you look back, those of you who know your healthcare history will know that in the mid-19th century, the idea of what was called social medicine originated in Germany and other countries in Europe. One of the fathers of this movement was a German pathologist by the name of Rudolf Virchow, who was not a Harkness Fellow. But nonetheless, he made important contributions to both medicine and healthcare policy. And Dr. Virchow was working at the Charité Hospital in Berlin. In 1848, he was dispatched to Upper Silesia, which is a region of what was then Prussia and is now Poland, to work on an outbreak of typhus. And Dr. Virchow saw very clearly at that time that the epidemic was most pronounced in populations that were impoverished and dealt with issues of poor nutrition. He even went so far as to attribute some of the deleterious effects of infectious disease to political lack of power. And those ideas were very influential in the development of American public health movement here in this country in the late 19th century. And then again, 50 years later, those lessons seemed to be relearned by the architects of our community health center movement, who, as many of you know, in the mid-'60s, were very focused not only on medicine, but on the degree to which poor housing and nutrition influenced health. In fact, Jack Geiger, the father of the community health center movement, famously wrote prescriptions for food for his patients, and when he was allegedly questioned by the bureaucrats at the Office of Economic Opportunity and the Johnson administration about whether this was in fact allowed, he said, well, the last I checked, the prescription for malnutrition was food. Now, of course, we in this country, it seems, have struggled to keep up on these lessons. And one thing that sort of I take away from listening to today's panel, notwithstanding the fact that these opportunities often give representatives from other countries the opportunity to reflect and bash their own systems, as is the sort of nature here. Clearly, there are lessons that we can learn from abroad, and having gotten back earlier this year from a trip with help from the Commonwealth Fund to visit Germany, the UK, and Holland. I mean, it is striking that the strength of the primary care system, particularly in the Netherlands, I must say, and even in the UK, in the current stress that it's under after a decade of austerity, is striking from an American perspective, as is the investment in social services. And even if the coordination seems to be a challenge for everybody, there is no doubt, as Anne noted, that when you look at the data, the investment in social services elsewhere in the industrialized world is on a scale that we in this country simply have not kept up with. And I think there is an increasing amount of data that suggests that that has had a real impact. Now, the good news, I think, is that not everybody in this country has forgotten these lessons. And in fact, if you travel around this country, as I do for my job and for a book project I've been working on about primary care, if one travels around the country and visits the most developed systems of primary care in the United States, they are wonders to behold. And I spent some time at one of these systems, ChenMed, down in South Florida over the last couple of years. And we should all be so lucky as to have our parents or our loved ones be able to go to these kinds of systems. I'll tell you a brief story about a patient that I visited with recently at one of these ChenMed clinics in Fort Lauderdale in South Florida. Norma Delavante was her name. She's 69 years old. She's on Medicare. She's an immigrant from Jamaica who lived in South Florida most of her life, worked in home health, which, as you can imagine, is a growth industry in that part of the world. And she's an elegant, soft-spoken woman who also has diabetes and chronic back pain and advanced kidney disease. And she had a hard life. She injured her back and was forced to stop working. And for many years, she bounced around the mercenary hospital system and medical systems of South Florida before she ended up at ChenMed, which has a model that emphasizes a lot of the ideas that we talk about today and that some of the speakers here talked about. I remember I met her one morning at her house, and a van pulled up to pick her up to take her to the clinic in the morning. A very well-dressed van driver got out, met her at the door, helped her into the van. We drove slowly because the van drivers have been instructed not to drive too quickly because that's disconcerting for elderly patients. Slowly to the clinic. At the clinic, she was greeted in the waiting room by a physician's assistant. The waiting room is a lovely space decorated with orchids and serving lemonade off on the side. And when we got back to the exam room, after Norma's vitals were taken, the physician came to see her and talk to her about the medical issues she had. She had some persistent knee pain. And so they talked a little bit about what she was able to do, whether she needed physical therapy, whether she needed help at home. But importantly, the discussion also was considerably broader to the point of dealing with some of these issues. The doctor asked about her family. She lived with her grown daughter and her grandchildren, and her daughter had just had, I think, a third or fourth baby, and how was this impacting her health? And there was a discussion about her diet as a diabetic, but it was done in a very non-accusatory way, which research, much of which was done in the UK on diabetes, has shown is a much better way to communicate with patients. So there are ways that this can be done. And when you look at the data on these systems and you look at particularly what patients say about their experiences in this system, they're happy. mean, this is what they want. And, there's increasingly data that it can potentially impact costs because healthier patients, particularly those with chronic diseases like diabetes that are better controlled, result in lower utilization downstream. I want to end, though, because I don't want to spoil a perfectly good health policy morning with good news with a warning, because I think that if the experiences of Norma in South Florida and other patients like her around the country who are fortunate enough to experience robust primary care that is coordinated, that is compassionate, that is dedicated to the broader whole person care, as it was once called, if those experiences are sort of one future, there is a darker future. And we haven't talked today about cost burdens on patients. But from a patient's perspective, it is increasingly, at least in this country, the defining feature of interacting with the medical system. And we just finished a year-long, or we're finishing up a year-long series of stories that we did on the high deductible revolution in this country and the impact that shifting thousands of dollars of costs onto patients is. And needless to say, for those of you who live in this country, it is devastating. It is devastating, and the extent to which patients are rationing their own care is shocking. We did a nationwide poll with another foundation that will not be named, looking at the experiences of Americans with job-based health coverage, which was, of course, the gold standard for many years in this country of health insurance. And now 4 in 10 Americans with job-based health insurance report that they or someone in their family have delayed getting care in the last year because of cost. Well, you can't build a primary care, maybe the greatest primary care system in the world. But if people are afraid of how much the bill is going to be when they go, they're not going to access it. And I'll conclude with one sobering story to share with you about another patient that I met in the last year named Wendy Matney. And Wendy lives in Bristol, Tennessee, which is a city in the northeast corner of Tennessee that, among other things, claims to be the birthplace of country music. And Wendy lives in a mobile home outside of town with her husband, who has a job at Walmart, where he works in a distribution center. They have health insurance through Walmart, but unfortunately, it is a high deductible plan. And even more unfortunately, Wendy is epileptic. And Wendy has a form of epilepsy that does not respond to medication. So she has occasional, sometimes frequent seizures. And of course, every time you have a seizure, someone around you is pretty likely to call the ambulance because it's pretty scary. And every time the ambulance comes to get Wendy and takes her to the hospital, Wendy ends up in the emergency room, and very frequently she ends up with a lot of tests, and then sometimes she ends up admitted to the hospital, and that translates into thousands of dollars in medical bills. So Wendy and her husband now have $20,000 in medical debt. They've been sued by the hospital where she has been getting her care in this country, and that hospital is now garnishing some of the rather modest salary that her husband gets from Walmart to pay off these debts. And she said to me, I'm losing everything because of this. She can't afford to even fill her medications to control her epilepsy, which of course would be something that I would suspect a good primary care clinic would want to ensure that she did. So on that happy note, I will end with a warning that we better get this right, because we don't need to imagine what the future is going to be like if we can't, because people like Wendy are already living it. So I'll stop there. Thanks. Thank you.
Well, I hope you feel like you've gained some knowledge and some insight this morning. We have new data. We have reactions from various countries. We have the dose of reality about the system that this all is layered on top of. Thank you for joining us. Thanks to the Commonwealth Fund for your ongoing collaboration with Health Affairs on publishing these important results. And with that, We are adjourned.